You're watching CTOM TV. Knowledge is power.
So now we're going to go into monitoring, and monitoring is a very important aspect of cancer treatment. So typically, there's a few different ways that cancers are monitored. They're monitored through blood tests. They're monitored through imaging, standard imaging, typically CTs and MRIs. And they're also monitored potentially in some cases through liquid biopsies, although that is not quite standard practice as of yet. So blood tests typically include things like PSA, prostate-specific antigen for prostate cancer, cancer antigen 125, which is typically used in ovarian cancer, calcinotronin, which is often used in medullary thyroid cancers. There's alpha-fetoprotein, which is good for liver cancers, human HCG, human chorionic gonadotropin, and that's used for germ cell tumors such as testicular and germ cell ovarian cancers. And then there's CEA, and that's commonly used for various cancers. So these are standard blood tests. None of them are specific for a cancer. They're all markers of mechanisms that cancers use. So they can go up and down, and they're not necessarily an accurate diagnostic process. But doctors like to use these just as a way of seeing whether your cancer is moving in a growth direction or a repressive direction. And they do have some value in that context, although they're not that accurate. So imaging, typically CT and MRI is being used. And imaging typically includes a process called the RECIST criteria, which goes back to the types of responses you have. And so what imaging does is it looks at the size of a tumor and it monitors it as you go through your growth. And that is what we call serial imaging. And so what they do is they'll do a treatment when you first, they'll do an imaging, a CT or MRI when you're first diagnosed. They'll measure the tumor. And then what they'll do is they'll give you a treatment and you'll come back in 3 months, 4 months, and they'll remeasure the tumor and see if it's gotten bigger. And if it has gotten bigger, or hasn't gotten bigger, the doctors will classify your response under 4 different criterias. And this is referred to as a RECIST criteria. So it's important that you understand the different RECIST criteria responses and that you qualify with your doctor what responses he or she is referring to. So the first one is a complete response. It's called CR. So in this case, the tumor has completely disappeared and that's it. It's responded incredibly well and it's gone. The second type of response is called a partial response. And that's where you get at least a 30% decrease in the size of the tumor. And that's kind of a generalized approach to it, but that's called a partial response. It's still a response, it's still a good thing, but you haven't totally gotten rid of the complete tumor. Then you have stable disease where there's no growth and no reduction. And then you have, and this is a response, it's just a negative response, what's called progressive disease. And that's where you have at least a 20% increase in the volume of the tumor. And that basically means that the tumor is growing. Now, all of these refer to as responses. So when you ask your doctor about the response rates of a certain treatment, you need to look and see whether that response rate includes all of those, which is typically referred to as a disease control rate, or all 3 of those. The 3 are the positive responses, and the 4th is the negative response to progressive disease. So the disease control rate refers to the 3 of those. Now, you want to know what the complete response rate is. Obviously, that's the golden handshake. So if you look at a trial and your doctor says, well, this is a great drug for you, it has a response rate of 70%. And what you need to ask is you need to say, well, is that 70% a complete response? Is it a partial response? Or is it a stable disease? Or is it a composite of all 3? So obviously you want to know what the complete response rate is because that is the real important thing.
Yeah, it's gone though.
Yes. So this sort of imaging process is standard care. What we recommend is
you mean CT and MRI?
Yes.
Okay.
And it requires a RECIST criteria.
Got it.
Is the basis of the
because
RECIST responses.
they're assessing
measuring
based on the size
of the
growth,
tumor.
or shrinkage. Got it.
Not necessarily the best way to respond or to look at a response, because the RECIST criteria does not work well with immune therapy. Mm-hmm. And the reason for that is when you get immune therapy, about 30% of patients have what's called pseudoprogression. And that's where the T cells enter the tumor and break it up from the inside out and actually cause the tumor to get bigger. And so the tumors will actually grow in size when they're actually necrotic and dead. A CT and an MRI cannot tell that very well. And so what we always suggest is you get a PET CT along with these CTs and MRIs. And so the PET CT is really important. PET CT provides real-time analysis. In other words, you don't have to get a bunch of different tumors or a bunch of imaging over a long period of time to see if the tumor has grown and find out that the drug you've been on has not done anything and now you have metastatic disease, or the drug is working and you want to stay on it. You want to know that right away. And so a PET CT allows you to do that, and it doesn't require serial sequencing. And that is because the PET CT looks at what's called biological activity. What a PET CT does is it looks at the activity of the cells within that tumor, and it sees if they're highly metabolic. And the way it does that is it uses a radioactive isotope attached to a sugar, and they inject this into you before you get your PET CT. And then any tumors that are highly active are going to drink up a lot of this fluid. And it reports these values in the format of something called an SUV. That refers to the serum uptake value of this fluid. And so this serum uptake value of this fluid has a number. And that number can be used to determine whether that tumor is alive or dead. And so let's say you have a tumor and you get a drug combination, you get a PET CT, and that tumor has gotten bigger over time on the CT scan. But then you get a PET CT and you see that the SUV of that tumor is 1 or 2. You see that is actually a tumor that's not very active and it's dying. But you may have another tumor that's very, very small that hasn't grown much, but has an SUV of 28. That is a tumor that you want to have targeted with either radiation therapy or have it removed surgically, because that is a tumor that is likely to grow and metastasize, not the big one. A CT and an MRI cannot tell the difference between these two tumors, and often doctors will ignore a small tumor in favor of a large tumor that may in fact be dead. And this is why you get a PET CT, is it gives you real-time analysis of your tumors. Very important information. Mm-hmm. And you can look at tumors over time, and often with a PET CT is it will show partial responses. It'll show that while the tumors may not have gotten smaller, the SUV activity has gone down in the tumor over time. And that means you are responding to the drug, even though a CT or an MRI would show that the tumor is the same size. It doesn't matter if the tumor is the same size. What matters is whether it's alive or dead.
How aggressive.
And how aggressive it is, yes. So one problem with PET CTs is if you do have pseudoprogression in immunotherapy, a PET CT is not going to differentiate whether you've got pseudoprogression. And the problem is that the T cells within the tumor that are killing the tumor from the inside out are very active, and they're going to drink up a lot of this sugar solution too. And so they're going to mimic a live tumor. So if you do have immunotherapy, what we recommend is liquid biopsies. And the liquid biopsies we suggest are circulating tumor DNA. And what happens is the dead tumors will release this DNA. We prefer to use exosome-based liquid biopsies because they are a metastatic process. You can learn about exosome-based liquid biopsies on our website and on the Cancer Guide. And we have a website all about liquid biopsies that Nadine can post a link. But any kind of liquid biopsy is going to be beneficial for you when you're monitoring, preferably exosome-based. And that's because they look at the amount of the DNA released by the tumor. And so that is going to obviously change if the tumor is not growing. So if the tumor is dying, then it's this mutation that you're tracking on ctDNA, circulating tumor DNA, is going to decline. And so what you do is you can do a test where you measure your amount of your specific mutation. Let's say you have BRAF and you have colon cancer. You look at that mutation prior to getting treatment. You get your combination of drugs, and if it's immunotherapy, for example, then you look at how much that percentage has gone down over time. Then you know that you're responding to the treatment. And this will work for any sort of cancer. So liquid biopsies really are the future of diagnostics. They don't tell you where the tumor is, but they tell you the overall tumor burden based on the amount of tumor-specific mutated DNA.
Thank you for watching Cetome TV. Subscribe below and stay informed.